Welcome to another presentation by Health First. By the end of this presentation, you would have learned the need to screen, and you would have also learned the potential harms of screening and be able to appreciate the characteristics of a good screening test and also understand what is meant by validity of a screening test and be able to calculate measures of validity such as sensitivity, specificity, and also be able to calculate and interpret positive predictive values and negative predictive values of screening tests. Now, screening is a strategy that is used in populations to identify the possible presence of an asymptomatic disease in individuals. And of course, it forms a large part of secondary prevention. Why do we screen? So basically, the simple answer is to identify pre-symptomatic cases of a disease at a stage where usually you'd have a better chance of complete recovery and a higher chance of cure. Now, there are some important examples of screening tests, and one of them is the Pap smear. The Pap smear basically attempts to identify precancerous cervical lesions. So these are specific changes within the cells of the cervix that if left untreated, the majority of them would then progress with time to cause or to become cancer. In Botswana, of course, the worry and the majority of cervical cancers are caused by HPV. HPV is human papilloma virus. Of course, the Pap smear does not necessarily test for HPV. It only identifies microscopic cellular changes that are representative of a precancerous changes. The next example is the mammogram, which is used to detect breast cancer. And the next one, of course, is the fecal occult blood test, which is used to detect colorectal cancer. Not all screening is good screening. There are some disadvantages when it comes to screening tests. Most of them are around overdiagnosis and misdiagnosis. Take examples such as gallstones. Individuals can live quite for some time and a full life really with gallstones. Usually they will be detected post-mortem, and they live with them, and the gallstones do not cause any problems. So if you were to screen people for gallstones and intervene, you would find that you basically over-treating, right? You would be in a situation where you are treating gallstones that may never require treatment for as long as that individual lives. With false positives and false negatives, think of what happens to these patients, these two groups of patients, right? Let's take a mammography, for instance. If we know that young women between the ages of 20 to 30, 35 can get breast cancer, right? But the probability or the chances are very low, and the sensitivity of mammography is low because younger women have denser breast tissue. So many of the false positives will be subjected to of course worry and anxiety, and they may also undergo invasive diagnostic tests such as biopsies and surgical excision unnecessarily, right? So those are the consequences. So an example of a situation where a screening test turns out to be false positive. The next example, of course, is with the false negatives, right? When a screening test tells us that a patient does not have disease, when in fact they do have that disease. Now, with these patients, usually they get that false sense of security, of course, and these are patients that turn out to basically be missed, and they may get to a stage where the disease is advanced and is only noted after onset of symptoms. To consider a screening test good enough, it has to be, of course, cheap. It has to be easy, minimally invasive, meaning that it does not hurt the patient as much compared to a gold standard test. If you compare mammography, for example, with surgical excision, you'll find that surgical excision is more invasive, right? The patient will be subjected to some form of surgery. With a mammogram, is basically a modified X-ray, right? And the patient is not subjected to a lot of discomfort. When you talk of validity, we are talking about the ability of a screening test to accurately identify diseased, right, individuals with disease and individuals without disease. To decide whether or not a particular screening test is good enough, we usually compare it to a gold standard, and that gold standard in most instances is a diagnostic test. And the problem with a diagnostic test, of course, it's usually the exact opposite of a screening test. It will usually be expensive, and it will usually be invasive and not easy to perform. That's the reason why we opt for the screening test in the first place, right? So when it comes to validity, the measures that we use for validity are to sensitivity and specificity. These are also called pre-test probabilities, and it is important to understand that sensitivity and specificity are characteristics of the test, the screening test, right? We will discuss later on what is known as post-test probability, right? Post-test probability. The important thing is that in order to be able to calculate these pre-test probabilities, you need to construct what is known as a contingency table. This is how a 2x2 table looks generally, and the reason why it's called a 2x2 is you'll have 2 columns and 2 rows, right? And these 4 cells in the center will have specific numbers, and around will have the labels that refer to these cells and the information in the cells. Usually on the side here, you'll have the test result. On top, you'll have 2 groups, diseased, so that's disease, and no disease. Right, so those are 2 groups, and on the side, remember, this side refers to the test results itself. So you'll have the test positive, and you'll have a test that is negative, right? But remember that the reason why we are doing this in the first place is screening tests are not 100%. As we saw, they can be falsely positive or falsely negative. How do we know then that the reality that a patient has disease or does not have disease? We use, remember again, the gold standard. So this is basically the gold standard result, right? So when you are subjecting any new test, any new screening test, you would test individuals with that test and then test individuals with a gold standard test, the same individuals, and see how the two results compare. So from that, you will get individuals who really have disease testing positive. So we call that a true positive result. And you'll have individuals with disease who test negative. We call that a false negative. And then you'll have individuals who do not have disease who test positive. So we call that a false positive. And you have individuals without disease who test negative, right? And those are true negatives. To complete the 2x2 table, we usually have totals. We total the rows and we total the columns. If we are running a study and we have 200 participants, those 200 participants fall into one of these categories, right? So let's suppose we are testing a new screening test and subjecting it to this validity test. We will get these 200 patients being distributed among these 4 categories, right? So just hypothetically, let's say we have 80, 20, 40, and 60. These are easy numbers to work with. We would total this row. The total of this row is 120 patients. The total for this row is 80 patients. The grand total, of course, is 200, right? So the total for this column, this is 100. The total for this column is 100, and the grand total is 200. So this 200 is the total number of patients that we have in our little hypothetical study. From this table, we usually now calculate specificity, sensitivity, and we can also calculate positive predictive value and negative predictive value. Here's our contingency table. So remember, we had 100, we had 120, 80, and of course the grand total is 200, right? So in order to use this table to calculate sensitivity, let's first of all get the definitions of sensitivity, right? So sensitivity refers to, basically, it's the probability that the test will correctly identify diseased individuals, right? Diseased individuals. And another way of saying it is how accurate the screening test is at identifying disease in people who truly have disease. And the definition for specificity is accuracy of the screening test in correctly classifying non-diseased individuals, or the probability that non-diseased subjects will be classified as normal by the screening test, right? So remember, we said sensitivity is the probability that diseased individuals will be correctly identified, and specificity is the probability that non-diseased individuals will be correctly identified. The way I remember this in basic easy terms is that people with disease are sensitive, right? It's a funny way of remembering it, but it works. So individuals with disease are sensitive, so we use sensitivity. And of course, specificity will be those without disease. Now remember, it's probability. So we are saying sensitivity is the probability that the test will correctly identify diseased individuals. So we are interested in diseased individuals that are correctly identified. So that means that we are talking about the true positive rate, right? So is the true positives within the disease, individuals with disease, they are true positives, and they are this category here, which are false negatives. They are false negatives because they have disease, but the test says they are negative, right? So in order to get this probability of correctly identifying diseased individuals, we have true positives divided by the total number of diseased individuals, which will be true positives plus false negatives, right? So the formula looks like this: true positive divided by true positive plus false negative. That's sensitivity. So with specificity, it's very easy also. Remember, with specificity, we are dealing with the probability that the test will correctly identify non-diseased individuals. So how good is the test at identifying people without disease, right? So first of all, we have to identify the proportion that is identified correctly as having no disease. So that will be this category here, and we call those true negatives because the test said they are negative, and indeed they are really negative in reality. So those are true negatives divided by, remember, it's probability, so we need to divide that by the total number of patients or individuals without disease. So that's going to be true negative plus this category here, which is, remember, the test says they are positive, but in reality they don't have disease. So this is a false positive, right? So true negative over true negative plus false positive. Right? So this gives us specificity. Now, in terms of calculating this in numbers, it's easy. We know that we have our true positive is 80. That's 80 divided by 80 plus the false negatives is 20. That gives us 80 over 100, right? So 80 plus 20 is 100. So that gives us 80%, or you can call it 0.8 if you want to express it as a decimal. So as a percentage, it will be 80%. And then the specificity, true negative, we have 60 divided by true negative plus false positive. So 60 plus the false positives are 40. And this gives us 60 over 100, which gives us 0.6. If you wanted to express this as a percentage, of course, you would multiply this by 100, which gives you 60% specificity, right? So 60% specificity, 80% sensitivity. What do these numbers mean? So it means that if you were to test, let's say you have 100 individuals who truly have disease, this test would miss 20% of them and correctly identify 80%. 60% specificity means that 60% of individuals without disease will be correctly identified by this test. Of course, these are just numbers. They are not reality. They are just a representation of reality. The next discussion is on predictive value. Predictive values are often referred to as post-test probabilities because they they only matter really after the test has been run. That's why they are called post-test. For instance, if I tell you that I have a test, so let's take our previous test. We calculate our sensitivity as 80% and we calculated our specificity as 60%, right? So if I tell you that I have this new test, and if you are a patient, for instance, I will tell you that I'm going to run it on you, and these values are basically, remember, these are characteristics of the test. These are characteristics or properties of the test, right? So this is how the test performs generally. This is how good it is when it's done by an individual or by an individual who is properly trained to run the test. This is the best that the test can give you, right? So suppose now that I run this test and a patient turns out positive. Now, usually the question is, how sure am I as the doctor that this positive result is representative of reality? How sure am I of this result? So that is what predictive values are. They address the question of how sure we are about a test result. That is, how predictive of reality is the test result itself. There are two types of predictive values. We have a positive predictive value if the test result is positive, and a negative predictive value for a negative test result, right? So a positive predictive value is the probability that subjects with a positive screening test truly have the disease. The thing you have to understand about positive predictive value is that it varies with prevalence, right? So remember, prevalence, we are referring to prevailing, so that's the number of individuals with a specific disease at any given point in time in the population, right? Or it can be over a specified time period, right? So when we say positive predictive value varies directly with prevalence, we mean that if prevalence increases, the predictive value of this test increases, right? So if the number of individuals in that population with the disease of interest increases, then the positive predictive value will also increase. And then the negative predictive value is the probability that subjects with a negative screening test truly don't have the disease, right? So this is basically when the test turns out to be negative. So with negative predictive value, it varies inversely with prevalence, meaning that if prevalence increases, the negative predictive value or the predictive value of a negative test result decreases. The best way to actually think about this is to consider another hypothetical situation. Let's suppose you have two populations, right? This is population A and this is population B. And in population A, let's say you have 10 individuals, right? Or let's just say 6 individuals, right? 1, 2, 3, 4, 5, 6. So in A you have 6 individuals, in B you have 6 individuals. And in population A, you have one individual who has the disease of interest. So this individual is positive. They have the disease of interest. And in population B, you have many more individuals with the disease of interest, right? Let's say four individuals who are positive of or who truly have that disease, right? So if you were to run a screening test with a sensitivity of 80% and a specificity of 60% between these two populations, these numbers wouldn't change. These are pre-test probabilities. So these numbers would hold true for both this population and this population. But the positive predictive value and the negative predictive values will change based on the prevalence of disease. So making it really simple, let's consider the positive predictive value. The prevalence in this population of disease is 1 on 6, right? 1 individual in 6. And the prevalence here is 4 individuals in 6, right? So if you get a positive test result here and you get a positive test result in population A, the test result in population B is more likely to be true. Just by sheer numbers, it's more likely to be true than the positive test in population A. Why? Because you have more positive patients, high prevalence in population B. So the value of that test, its predictive ability, will definitely increase in population B. We use the same contingency table that we use for sensitivity. It's the same one that we use for positive predictive value. But the only difference is the perspective is different. Remember that our perspective when measuring sensitivity was individuals with disease, right? We were trying to find out how good is this test at identifying individuals with disease. And for specificity, our perspective was individuals without disease. We were asking the question, how good is this test at correctly identifying individuals without disease? Now, for the predictive values, we go now to the other side of our 2x2 table. Now, for the positive predictive value, our point of view is the positive test. And for negative predictive value, our point of view is the negative test result, right? So a positive predictive value, the probability that individuals with a positive test result truly have disease. And we see from this 2x2 that individuals who truly have disease are this 80 here, right? So it will be 80. Remember, again, it's probability, right? It's a risk, it's chance. So we are going to divide that by the total of individuals who test positive, right? Both the true positives and the false positives, right? So we are basically taking all positives, whether true or false, in order to calculate the positive predictive value, right? So actually the formula itself will be true positive divided by true positive plus false positive. And of course our true positive is 80. That's divided by 80 plus 40. This gives us 80 over 120, right? And this can be expressed as a percentage and it gives us 75%. Right, so the positive predictive value of this test is 75%. Right, so what about the negative predictive value? You can pause the video right now and then calculate it and then check your answer. Okay, let's calculate the negative predictive value. So the negative predictive value, we are only interested in the negative result, right? So we are interested in the negative result. All of these are negative results, right? This one though is a true negative because these are individuals without disease who test negative. This one would be a false negative because it's individuals with disease who happen to have tested negative, right? So the formula for this one is going to be true negative because we are interested in the probability that individuals with a negative result truly do not have disease, right? So it's going to be true negative divided by true negative plus false negative. Note that for all of this formula that we use for sensitivity, specificity, and also for these predictive values, we always have truths on top, right? Truths on top, always. So this is going to be true negative, which is 60, divided by true negative 60 plus false negative 20, and we have 60 over, this is 60 divided by 80, right? 60 divided by 80 gives us 75%. Okay, so we have a positive predictive value of 66.7% and a negative predictive value of 75%. So this means that if a patient were to test positive with this particular screening test, then there is a 66.7% chance that they truly have disease. And if they were to test negative, then there is a 75% chance that they truly do not have disease. Remember that the reason we do this and the reason why we study this in epidemiology is that it becomes important usually when interpreting epidemiological studies, and it's important to be able to, for instance, read a study such as this one and be able to interpret it and understand really what it means, right? So let's take some time to go through this, and at any point feel free to pause and attempt some of the calculations on your own. The scenario starts or tells us that about the methods, the results, and it gives us a question, right? So it says PSA means prostate specific antigen. So PSA testing results were compared with a reference standard of prostate biopsy, right? So prostate biopsy is the gold standard. PSA is the screening test. Subjects were 2,620 men, 40 years and older, undergoing PSA testing and biopsy. So they underwent the same test, the screening test and the gold standard. Remember, this is required because you need to compare the screening test to a particular standard to really say how good that screening test is. Diagnostic measures included sensitivity, specificity, and likelihood ratios. So we are interested in sensitivity and specificity since we have we are yet to discuss likelihood ratios. So results, it says cancer was detected in 930 subjects, right? The PSA cut point of 4 nanograms per ml had a sensitivity of 86% and a specificity of 33%. Right, so that's all the information you need to answer this question. So the question goes, what was the positive predictive value? And of course, what does that mean for this study? And what was the negative predictive value in this study? And what does it mean? So note that we are told that there were 930 men with confirmed prostate cancer. So this is the column total for cancer, right? So the best way to approach this question would be to come up with a 2x2 table, right? So for instance, we know that on one side we are going to have reality, right? And reality will have disease and no disease. But in this case, remember that the disease is cancer. So cancer and no cancer. We're going to have cancer and no cancer. This is reality because it's confirmed by a gold standard. And the gold standard that was used here is biopsy, right? So tissue was taken from these men and analyzed to see if indeed they had cancer. Whereas the PSA, prostate-specific antigen, is a screening test that looks for this particular antigen in the blood. Right, so it doesn't directly look at tissue from the prostate. Right, so here we'll have a PSA, prostate-specific antigen, positive. So that means greater than the cutoff, which is 4 nanograms per ml, and a PSA negative, which is a PSA of less than 4 nanograms per ml. And then we'll have our totals. We know that cancer was, there were 930 men with confirmed prostate cancer. That means men with cancer confirmed, we had a total of 930. And we know that there were a total of 2,620 individuals, 2,620 men in this study. So it means that if 930 of them had cancer, a total of 2,620 minus 930 who are cancer-free or had no cancer, right? So that comes to 1,690 individuals without cancer by biopsy. And we are told, remember, that the sensitivity of this test is equal to 86%, and the specificity is equal to 33%. So from this information, we can easily fill out the remainder of the cells, right? Because we know, for instance, that here we'll have true positive, here we'll have false positive, here we'll have true negative, and here we'll have false negative. The sensitivity is equal to 86%. It means that of the 930 individuals with disease, 86% were correctly identified in this study, right? So we are going to have to calculate 86%, which is basically 86 over 100 of 930, right? So this gives us a value of 800. So these 800 are the true positives, right? 800. By simple subtraction, the false negatives will be 130, right? So, and we do the same with specificity. We are told that the specificity is equals to 33%. It means that of the 1169 without disease, remember that specificity concerns itself with correctly identifying individuals without disease. So this 33% refers to the correct fraction or the correct proportion of individuals without disease, right? Or individuals without disease who have been correctly identified, right? So that will give us 33% of 1690. That value comes to 558. Remember, you have to round these figures to whole numbers, to the nearest whole number. So this is what happened here. And this means that if we have the false positives and the true negatives equaling to 1690, the remainder here will be easily calculable by saying 1690 minus 558. This will give us a total of 1132, and that's 1132. So then we are just left with the task of just adding up the totals in the rows, and this totals up to 1932, and this totals up to 688. With this information now, we have enough now to calculate what the question asked for, which is the positive predictive values. Let's now calculate the positive predictive value. Remember, positive predictive value, the formula is simply the positives. We are only concerned with the positive results. In this case, this row, right? So it's going to be the true positives divided by the true positives plus the false positives, right? So truths are always on top, and since we are dealing with positive predictive value, we are only interested in positive results. So this gives us 800 divided by true positives, which is 800, plus false positives, 1132, right? So this becomes 800 divided by 1932. If you are to express this as a percentage, it will become, you multiply by 100, and this will come to 42%. That's the positive predictive value. So the question also says, what does this mean? So this means that in this particular study, the probability of having biopsy proven cancer was 42% given a positive test result. Or you may say, given a positive test result, there is a 42% or 42% probability that an individual in this study would have biopsy-proven cancer or prostate cancer. Now let's move on to the negative predictive value. The negative predictive value, remember we are only interested in the negatives, right? So that's negative predictive value, only the negatives. And that means it's this particular row. Truths on top. So truths are always on top. So we start with true negative, since we are only interested in the negatives, divided by true negative plus false negative, right? So this comes to true negatives. We have 5, 5, 8 divided by 5, 5, 8, that's 558, plus false negatives of 130, right? So this gives us 558 divided by 688. Multiply this by 100 to express it as a percentage. This gives you 81%. So this means that the probability of not having prostate cancer among men with a negative PSA test was 81%. If you have any questions or need any clarifications, then feel free to contact us, and the details are below.